All gathered, Marie. Joe Webster's going to be joining the meeting slightly late, so I think we're ready to go. Yeah.
Okay. Okay, I'll make a start then. Thank you very much, everybody. Just a few welcomes and introductions first. I'd like to welcome to the meeting. It's our second meeting via Teams. I'd like to welcome our two new CCG lay members. First, we've got Ruby Barty from Bradford District and Craven CCG, so welcome, Ruby. And we've also been joined by John Malaheur. Excuse me, John, if I haven't quite got your surname right. I presume it's French. But welcome to both of you. Both of our new lay members, obviously remember, replaced Richard. They've both got experience in extensive healthcare and care services, and I'm sure will bring that independent challenge in that we're looking for. So welcome to both of you. I'm also pleased to announce that Robin Tudham, Chief Executive of Calderdale Council, has now been appointed as the Accountable Officer for Calderdale CCG, and he takes up his new role later this month. So I think in the meantime, Neil will be with us, and he may be with us for the foreseeable future, but at the moment he's the Accountable Officer until then. Additional attendees today include Esther Ashman, Commissioning Futures, Pat Keane, Keith Wilson and Rod Barnes, who's Chief Executive of Yorkshire Ambulance Trust for Urgent Emergency Care, and Claire Smart and Andy Wee, who will be doing the assessment and treatment units. We've also got in attendance Sharon Hodgson, Senior Programme of Care Manager, NHSEI, shadowing Joe Webster when Joe eventually joins us. The only apology I've received this morning, unless Stephen's got any more, is from Stephen Cleesby. Any more, Stephen?
Yes, Chair, we've also had an apology from Matthew Groom, and I think Sarah Holstead is attending in Matthew's place.
Okay, thank you. So as you know, we continue to operate in a challenging environment with COVID infections arising across the country, and West Yorkshire is above the national average, and we've localised restrictions in Bradford, Calderdale, Kirklees and Leeds. We're seeing this translate into high cases in hospitals, and unfortunately deaths are resulting as a factor of this. These are still significantly lower than in the spring, but we're heading in the wrong direction, unfortunately. Clearly, this is a precarious time as we move towards winter and the conditions in which respiratory infections thrive. Partners across the NHS have been planning for the restoration of essential services. This is an important and challenging task as we try to balance the competing requirements of non-COVID and COVID services. We are very grateful for the work of all staff across the NHS, care services and other public sectors for the work they're continuing to do, and like to pay particular tribute to all of them for their hard work and commitment. As you know, our shared mission remains to join our services so that we meet the current and future needs of people of West Yorkshire and Harrogate. In such challenging times, collaborative working is therefore more important than ever. And I think that really was a spiel I gave there, and that was just basically to say, you know, thanks very much, everybody. And, you know, let's manage the winter and COVID as best we can and stick together as a team. So thank you for that. In terms of the rest of the meeting, then, the domestic arrangements, can I ask you to keep your microphones on mute unless you're presenting. Put your camera on when you're presenting and speaking, please. And if you can, use a raised hand function to let me know. If I don't see you, then wave frantically at the camera, and I'm sure somebody, either myself, Stephen or Ian, will pick you up. And then finally, for me, in a formal response again, it's just to let you know the committee is made up of 6 West Yorkshire CCGs. North Yorkshire CCG is now an associate member. It has delegated powers from West Yorkshire CCGs to make decisions on specific work programmes. Although the committee supports the Health and Care Partnership, it only includes CCGs and does not represent all partners. It is not the business of the committee, therefore, to deal with issues in the 6 places which make up our partnership. Okay. Moving on, in terms of the next part of the agenda, questions and askings. As you know, we ask the public if there are any questions for this particular meeting. Today we've received one question which I'll ask Stephen to read out to us. Stephen, over to you.
Yes, thank you, Chair. Yeah, this is a question from Dr. John Puntis, who says, in Simon Stevens' letter of 31st of July to CCG accountable officers and others, he noted plans to streamline commissioning through a single ICS STP approach. This will typically lead to a single CCG across the system. Rob Webster, chair of the partnership, has previously been quoted as saying, moving to one CCG for West Yorkshire and Harrogate would risk undermining our approach and our relationships with our local authorities who are equal partners. We have no intention of doing so. How does the Joint Committee see these two positions being reconciled? And what we're planning to do is to respond to that item under the agenda item on commissioning futures, which picks up a number of related issues. So we'll respond as part of that agenda item, and we'll also produce a written response as well and post it on our website as usual.
Okay, thank you very much indeed, Stephen, for that. Okay, moving on to the next agenda item, declarations of interests. We've asked members obviously fill out their interests. Is there anything on the agenda today that anybody would wish to declare in addition to what's already been disclosed? Any declarations of interest today? I'm not seeing any raised hands, no. Okay, on that note, please, then I'll move on to the minutes of the meeting held the 7th of July. Is there anything on the meetings people would wish to amend before we approve? Anything on the amendment side, please? No. Okay, are we happy to approve the minutes of the 7th of July? I presume we are, if I don't see any. Yep, I see some nods going. Thank you very much, Tim. I can see you on my screen, so thanks, Tim. So yes, thank you very much, everybody. The minutes have been approved the 7th of July. We then have actions and matters arising from the 7th of July. Stephen, could you update us, please?
Yes, Chair. We have 3 items on the action log which are currently in progress, a couple of which are scheduled for future meetings of the committee. We have 2 items which are complete. The item on joint committee governance and the item on commissioning futures are picked up as items on today's agenda.
Okay, thank you very much indeed. Anything else anybody would like to raise on the matters arising and the actions? Nope. Okay, thank you, everybody. I'm going to move on now. Has Esther joined us yet, Stephen? Yes, she's on the line, isn't she?
No, I don't think Esther has joined us. She was planning to be a little late. So
okay,
what I'd suggest we do, Chair, if it's okay with you, because we've got a number of external speakers speaking on items, is if we perhaps take the item on joint committee governance first, which is my item. If we take that first, and hopefully by the time that's finished, Esther and Joe will have joined the meeting, if that's okay.
Yeah, that's fine. You probably think I'm rattling through this is because I'm sat here with labyrinthitis and I'm struggling to read a bit, really, so apologies for that. So I'm wobbling a bit in front of the screen. So yeah, let's take your item first then, Stephen. That'd be great. Thank you.
Okay, yeah, thank you, Chair. So this is item 9520 on the agenda, joint committee governance, which just brings the joint committee up to date on 2 or 3 outstanding governance issues. The first is to just formally report the appointment of the two new CCG lay members, which you've done in the introduction, Chair, and also reference that as per the discussion at the last meeting, there's been discussion at the PPI Assurance Group about the future role and membership of that committee, and the role of the committee we're looking at in conjunction. I'm looking at in conjunction with the chair in relation to making sure it's aligned with a kind of wider move towards system working that the commissioning futures work is bringing us. So we'll be bringing a future report to a future meeting of the joint committee around that. The second item, just to draw your attention, is the formal agreement of the Collaborative Commissioning Memorandum of Understanding and Work Plan, which, as you know, was approved by the Joint Committee to go out to the individual CCGs back in March. Pleased to report that that's now been formally approved by each of the CCGs, and the MOU and the work plan is attached at Appendix 1 of the report. So that now formally delegates to the Joint Committee some new commissioning decisions, which are set out in Schedules 2 and 4 of the MOU. And it also reflects changes in the membership of the committee in relation to the position of North Yorkshire CCG. Now that we've got the Joint Committee's work plan formally approved, we've got an agenda plan for the rest of this year, and the draft agenda plan for January set out in the report. And we'll be bringing a full agenda planner for 21-22 to the meeting in January. And finally, again, now that we've got the full work plan formally approved by the CCGs, we're bringing back to the Joint Committee the risk management report, which, as you know, sets out significant risks to the delivery of the Joint Committee's work plan. And that's all risks which are scored within programme boards at 12 or above. This is shown at Appendix 2 of the report. There are currently 7 risks scored at 12 or above, 1 in relation to the cancer programme and 6 in relation to the Improving Planned Care programme. And these are set out in the table. As maternity services has only just been added formally to the Joint Committee work plan, we also felt it would be useful to cite the Joint Committee on any significant risks to delivery of that work plan, and that's also included in the table. It's scored at below 12, so it will be excluded from any future reports, but we just felt it would be useful to cite the Joint Committee on that risk. And risk to delivery of the Commissioning Futures programme will be reported to the next meeting in public. So members are asked to note the appointment of the 2 new CCG lane members, note that the new MOU and work plan has been formally agreed, and to review the risk management framework and comment on the actions being taken to mitigate those risks.
Thank you, Stephen. Any comments from anybody that you wish to raise on that? Yes, please, Ruby.
Stephen, does the risk plan reflect the changes that have happened recently with COVID? With the higher, with the higher testing, with the changes, Bradford being high at risk, for example, West Yorkshire, is your risk plan reflecting that?
Yes, a number of the risks, certainly the cancer risk and some of the risks in relation to the Improving Planned Care programme are directly related to the issues that have been caused by COVID, yes.
Thank you, Stephen. Okay, no more questions on that there. Well, thank you, Stephen. So we do note the 2 new appointments and the MOU work plan and the risk management framework. Thank you very much indeed for that. Okay, Esther's still not with us and neither is Pat Keane, so I'm going to move on. The other item we've got on the meeting is mental health. That's Claire Smart and Andy Weir. I'm looking for them. We're not doing very well here, Stephen. You're on mute. Would you like to bail me out here, Stephen? Somebody needs to bail me out.
I would like to bail you out. I thought I'd bailed out by taking the Joint Committee governance item first, but we're clearly still awaiting Esther joining the meeting. Not quite.
Helen, do you want to just? I've got Helen with us. Helen Hurst. Helen, would you like to just do the mental health paper? Would you mind?
Do you want me just to fill in?
Yeah, I want you to fill in. Otherwise, we're going to sit here like a bunch of lemons. So yeah, fill us in, please, because this is getting a bit. So let's do mental health and learning disabilities and autism, if that's okay. Could you just fill us in on that, Helen?
Okay, let me just bring it up on my iPad. So, and I won't do justice to it in the same way as Andy and Claire will have done, but members of the committee. Oh, somebody's here to support me. Oh, it's Karen. Of course, Karen. So members of the committee, we've had this discussion on a number of occasions around the reduction of our planned bed base around our assessment and treatment units for people with learning disabilities. We've also done, we had some quite comprehensive engagement work that we were setting off on, and then we got rudely interrupted by COVID and weren't able to continue as we'd intended. And it may be that Karen is able to just explain a little bit about where we have got to with that. The main reason for bringing this paper today is to sort of, I guess we'd had discussions around what the commissioning model was going to be, and the extent to which we can move to a joint approach across the CCGs, or could we actually go a little bit further and adopt some of the thinking and the philosophy that we've seen with what was called new care models in mental health and learning disabilities, where in effect you can identify the resources that are spent on this service, and the providers through their provider governance arrangements that they've established under their transfer of things like CAMS and eating disorders could maybe look to manage the risk, if you like, and manage the entirety of the resources. So this doesn't go as far as make a detailed proposition on that regard. What it does is ask for a whether or not as a committee we support that direction of travel, which is a change from where we were last as a joint committee when we talked about this being a collaborative commissioning arrangement. So that specifically recommendation number 2 is about that sort of that direction of travel and that move towards taking a different approach that we wanted endorsement of. Clearly there's a lot of detail still to go through in terms of that specific recommendation, but this is about getting sign up to a direction of travel. So I'm sort of taking this as sort of number 2 first. No reason other than that is the one I am the most familiar with, because that is the thing I have done the most work on. Because the work on the future model has been very much a sort of provider commissioning sort of partnership, and the work that it's set out in here in terms of our where we're getting to in terms of sort of being able to develop that approach, and where we're getting to in terms of being able to have a single model of care that goes across the whole of West Yorkshire, rather than it being a Bradford, a Leeds and South West Yorkshire based in Wakefield. So that's the sort of, there's the general update piece, there's then the commissioning piece, and then I don't know if Karen, you're able just to give a little update on the consultation and engagement work. It wasn't consultation, it was engagement work that we agreed with the joint committee of us.
Yes, absolutely. If you don't mind, I will turn the camera off though, just so I can refer to my notes, if that's okay, please. So basically, we've had, we were all set to go, which is so disappointing in March. We were just about a week to launch our engagement work, as agreed with the West Yorkshire and Harrogate Joint Health and Overview Scrutiny Committee. We did even consider whether we could do some engagement work virtual using digital technology, but as of course the COVID pandemic hit with a further force than what was any of us could have expected, we felt that that would just cause more concern to people who access the 3 assessment treatment units in Bradford, Wakefield and Leeds and their carers, so we paused. So what we've been doing in the meantime is we've still been liaising with our expert advisor Inclusion North, who are a specialist organisation who advocate for people with complex and moderate learning disabilities. And we're now ready to engage, so we're delighted to be able to do that. We took advice from the Assessment Treatment Unit Steering Group, which is made up of all the staff and the managers and also community organisations, as well as it's got some council representation on there and a patient advocate voice too. And they felt that it was okay and it was good to go now, as long as that we reached people via their familiar relationships that they have with the people that support them in their care. So we're not going to be doing any face-to-face work at the moment, but what we've agreed is that the staff who work in the 2 and 3 assessment units, they will engage people via their ongoing relationships on a day-to-day basis. We also want to absolutely make sure that we reach people, and there's potentially around 200 people over the last 2 to 3 years who have used the assessment treatment units, to make sure that we take into consideration all their views and what their experiences are. So to do this, we've done a questionnaire, and that'll be going out free post to them too. Now then, letters will be coming out via their assessment treatment units, because we don't want to take that personal data from away. There's also a questionnaire online for people to complete, so anybody can complete that. Anyone who would like to get involved and been involved in the units, and we're also doing some staff engagement as well. Now, some people might not want to complete a questionnaire online, or they might not want to do a written format. So we're actually offering people a questionnaire to do over the telephone, again, with people who know them. And then that'll be part of, we're giving the opportunity for them to be part of a virtual online discussion with professionals, and we'll arrange some setup calls for that too. So some of the practicalities really is that what we'll be doing is we'll be also engaging with our intensive support units who support people, and they'll be talking to people for the providers of feedback from hospital admissions as well, and they have a close relationship with people who work in our communities, so that's closer to social care perhaps than what some of the assessment treatment unit staff are. So the good news is, at last, we're really pleased to get to be able to do this and to look at what the impact is on people who've accessed care by taking out the Leeds unit, is that we want to go live this week. So the survey is now open on our website. So please do get involved and share that with anyone you know who would be interested in sharing their views. And we've got some virtual interviews set up for around the 12th, 15th, 19th and 21st of October, and that'll involve experts and people with lived experience. We'll then collate all that information, really important that we do a thorough job of this, again looking at any gaps that we might have, and we'll discuss that with the assessment treatment units and advise whether we feel as engagement and comms people that we need to do more work. And then we'll do some face-to-face group discussions if any of our staff teams want to do that later on this month. And the closer engagement will be around the 20th of November. This means hopefully we should have a report that for around about the early December, and we'd like to bring that back to the Joint Committee, please. Really important that we take the lead from our Health Overview Scrutiny Committee, and we'll be, of course, keeping them updated throughout and taking that report back to them. So I'll pause now, if that's okay, please, and just see if anybody's got any questions.
Yeah, thanks, Karen, for that detailed explanation. And any comments, Helen, do you want to come back on that?
Yeah, so I guess in terms of the model, so in terms of the detailed sort of model of delivery and care, that will not come back to this joint committee until probably December or maybe even January. And so I think what we're asking people to concentrate on today is then in terms of the commissioning approach that we're changing, both the fact that it's now on our work plan, which I think we'd already agreed actually at our last meeting, Stephen can correct me, but then the shift that we're making away from collaborative commissioning amongst ourselves to collaborative commissioning with our provider. They're the things we want to specifically endorse today. Being aware, and thank you very much for that very thorough update, Karen, that the detail about what we're commissioning comes back after the end of that engagement process.
Yeah, thanks for that, Helen. Okay, to the committee then, any comments on what Karen or Helen have said? Yes, John, please. John Malalieu. John?
Thanks, Marie. Look, I think it makes a lot of sense. I think the shift to a provider engagement in this commissioning is the only way when you're trying to get from a place of assessment and treatment unit to include step down into community services. And so we've always got to remember there's a whole breadth of providers in that community service space, including third sector and voluntary organisations who will do things for this population that we need to make sure doesn't suffer or doesn't get forgotten. One thing I would like to see, Chair, if I may, when it comes back, is a little bit more about the provider risk bearing here. So there's a very clear definition that if people need to go out of area, then the provider collaborative has to foot that bill. There might need to be a tolerance on that. Sometimes people need to go out of area for things that the provider can't control. And then we might just need to think about whether there's a squeeze point or whether we're absolutely robust about the financial envelope, but I'm sure we'll get a bit more of that when we get the model. So thank you.
Thank you, John. Neil, please. Neil Smurthwaite.
Thanks, Chair. So it's just to sort of answer a bit of John's sort of question. One of the things we've talked about previously, which is why the recommendation there, John, around the new model and the whole pathway, is to enable the money to be managed and the whole pathway to be managed better. We got a bit bogged down in buying beds, and that's when everyone got shares and who pays what. So we recognised we needed to look at the whole pathway and hence bring it back to get that support today. So I'm fully supportive of the recommendations, and I think it will help manage the risk and give better outcomes in the long term.
Thanks, Neil, for that. Yeah, we're getting a nod there from John, so I presume that's fine. Okay, so that was that. I think you did well there, Helen, and to give us an update on that paper. Any more questions from anybody else? No? Okay, I'll move on then. We should now have been joined, which we have been, by Esther. So Esther, you've saved the day, may I say. So Esther, can we move on to item number 9120, please? Commissioning futures. Esther, please.
Thank you, Chair, and apologies having IT difficulties getting in today. So we've been working for some time as part of the Commissioning Futures programme, working as commissioners together in partnership with providers and across sectors to develop a model for commissioning in West Yorkshire. And for the purposes of this work, it's just worth pointing out that we are just looking at West Yorkshire as Harrogate for commissioning, predominantly aligned with the North Yorkshire footprint. So it's just important to point that out. This work's really important in the context of the national direction of travel too, particularly around the development of integrated care systems. And the paper sets out some of that context, setting out the 6 work streams which are being explored as part of its development. And it's important to note that there's an increasing emphasis on an approach to commissioning through one CCG aligned to the ICS, but we're continuing to push back on this and influence as a partnership that this isn't the right model for our partnership and our populations. We've been very clear on that as we've gone through this journey. And I think this paper articulates what we think is the preferred model for our partnership. So sets out that articulation and narrative of what we think the model should be. As you'd expect, for West Yorkshire, place is central to our model. This is a West Yorkshire model built on the uniqueness of our places, and we only commission at ICS level where we can't do it at place. We only commission in place where we can't do it in communities, and only commission in communities where individuals can't do that for themselves. We know that commissioning's changing, and we want to embrace that and transform the way in which we do things. Commissioning should be a partnership activity, and that's what we believe it is in West Yorkshire. We want to move away from contractual type arrangements between commissioners and providers. We want to use integrated care type partnership arrangements at place with commissioners and providers, including local authorities. And locally, our place-based systems will set the strategy through their strengthened health and wellbeing boards and enact the delivery of those strategies through these integrated care partnership arrangements. And in order to deliver those ambitions, we want to align our leadership capacity as well, work as single leadership teams locally, leading on behalf of each other as the representatives of our places. And we know we're all in different parts of that journey at the moment, but that's the ambition to move towards that. We also want to explore our relationship with specialised commissioning as well to ensure that we're able to ensure an approach to whole population thinking. And the model we've developed sets a framework through which commissioning will take place in broadly 3 pillars. It'll either be commissioning which happens in each place, tailored to local population need and focused on improving population health, developed and delivered collaboratively as a system in that place. And then commissioning which is developed once, collaboratively in partnership across an ICS footprint, tailored to population need with a focus on improved population health, but delivered separately in each place to a common specification or set of outcomes and standards that have been defined at that ICS level. And then where we should see most commissioning is where it's developed and delivered once in partnership across the West Yorkshire, the least commissioning is where it's developed and delivered once in partnership across the West Yorkshire and Harrogate footprint, tailored to the cohort of the population and with an improving population health focus. And we should only see that where it's not possible to do it in place and where it meets the 3 tests that we've already set out as a partnership. Place remains central to the model and they'll continue to evolve as they move towards a system by default approach at place. We'll move away from a model of traditional commissioning to a model where we work together as partners across our place to deliver more integrated care for our population, support a greater focus on prevention and the wider determinants of health, and support our populations to be empowered to manage their own health and wellbeing and to enable health and care needs to be addressed around local neighbourhoods as well. And as part of the development of the model, we're also developing a set of financial principles that will support this work, focusing around financial risk share to help us individually to manage high risk fluctuations, agreed financial management arrangements in order to enable us to do things together, and agreed financial arrangements to support the development of the Commissioning Futures work as well. So as you should see from the paper, this is very much a partnership framework for commissioning, not a commissioner's one. It's been co-designed across places and sectors and has been and continues to go through quite an extensive engagement programme across partners. And we're now developing an operating model for this, which sets the narrative for the way in which we will work in the future, and what that means for our places, for our organisations, and also for our people. And we're working with programme leads to describe what the added value to working across the ICS will be and what the work will look like. And once we've completed the draft of this document, we will be sharing it with Joint Committee for comment and approval. But the areas that you will see in there are the things that at the moment we already have in the Joint Committee work plan, things like planned care, mental health, cancer, urgent and emergency care and maternity services. So these are things that you will recognise, but we will be able to describe what the added value of doing it in a different way will be. So that's the majority of the update of the paper. I'm happy to take any questions, unless Jo, as SRO for this programme, whether you have anything in addition you'd like to add.
Hi everyone. Sorry we were late. We were presenting this to another group, Marie. So sorry about that. I think I would add that particularly the question raised by the public about our approach to one CCG per ICS and that question. And I think this is our preferred model, and we believe as a partnership, not just as a group of CCGs, that this model will better serve our patients and the public in our local places, but also recognises that some of the problems that we do face, we will need to come together and make best use of our expertise, intelligence and resources differently in order to tackle some of those bigger problems. So we feel that we're not atypical. We have a very strong approach to collaboration across West Yorkshire. We have a very strong and we have demonstrated this by some of the work that we've already done. Some examples of that are the way in which we've shared best practice around healthy hearts, the way in which we approach stroke reconfiguration of services, and other things that demonstrate that this model works. So we know there's more to do, and we're mindful of the need to be flexible and agile in our approach as the national policy unfolds. And I think that probably, just to add to what Esther says, answers the question raised by the member of the public today. So this is our preferred model, and this is what we intend to continue to develop, emphasising the need for moving away from language of commissioner and provider to more of a population health management approach, and fitting our resources into that very differently, working in partnership across the whole of the system.
Thank you, Jo. And I think it's reflected in the paper and the language and everything. So I think there's a definite shift and a move in position. OK, any comments from any of the committee members? I think it's where we're heading, isn't it? So yes, John, please. Again, John.
Thank you, Chair. Jo, Esther, thanks for this. I think it's the direction of travel where what we're saying is one size nationally does not fit all for our place. And I think there's a couple of things that, not for now, I don't want answers now, they're things for us to think about as we go further forward. One is around making sure we're able to articulate that in one or two simple sentences that enable us to not spend time having to defend our approach, but actually prove its worth with the level and quality of outcomes that we get for the patients that we are charged with serving. The second bit is just an ongoing challenge, I think, that we've got to make sure that everybody at the lower level of place understands this as well. So I'm thinking about, the health leaders across a particular CCG area, which includes your clinical directors, which includes your LMC and all those type of areas, because to make this work, everybody's got to be focused on that population health outcome, and actually whether it's one CCG or 6 CCGs will stop mattering if the quality's right. So just like to raise that and keep seeing it as we move forward. It's in the paper. I don't want to lose it.
OK, thank you, John. You're right, though, it is in the paper, and I think that's reassuring. And I think you're right about the importance of place. And I mean, that's been our main mantra for West Yorkshire, which I think, we haven't shifted from, hopefully. OK, any other comments from anybody else? No. Well, thanks, Esther, as usual, and Jo, a really great paper, and obviously keeping us appraised and keeping us involved as we move forward with this interesting agenda. So thank you very much, both of you. And I know you were late in joining us, but you saved the day at the end of the day. So I've got more people online now. So thank you both. But thank you, Esther, in particular, for coming and joining us. Thank you. I know Jo's staying with us. Okay, thank you, everybody. I'm going to move on, if I may, then, because that paper was to note the discussion. The next item is the urgent and emergency care item. I'm looking for Pat Keane, and indeed, I should have Keith Wilson with me now. Have I got both Pat and Keith with me?
Morning, Chair.
Yeah, I have indeed. Thank you very much indeed. Okay, Pat, I'm going to hand over to you then, Pat, if I may, to lead this particular paper, and we'll take questions afterwards. Okay, thank you, Pat.
Thanks, and I hope my beautiful assistant Stephen's going to do the presentation. Thank you very much. So, well, good morning, everybody. Thank you for this opportunity. So we've got two presentations this morning. The first one is on the implementation of NHS 111 first. I recognise there's a fair few slides, so I'm going to focus on some of them more than others, Chair, if that's okay. And then, happy to pick up questions, any queries at the end, if that's all right.
That's fine.
Okay, Steve, could you move on to the next slide, please? And the next one, please. So, as outlined in the slides, this is a national initiative built upon NHS 111, which clearly has been in place for some time now, for several years. And really, there are a couple of things that are the background to this. It's learning from the pressure that we've seen nationally and locally as associated with COVID-19, and some of the ways that the digital opportunities and the different relationships that we've had to build in terms of both communicating, advising and treating people, some of the learning that's come out of that, recognise the fact that there is an opportunity to provide a more robust advice and treatment to individuals in their urgent and emergency care need, particularly in the urgent need, where there is an opportunity to route and advise and treat people as an alternative to contact the emergency department. I must emphasise at this stage, this is not saying that people cannot and should not go to ED if they feel a need, and it's very clear in the specification that's the case. What this is about, particularly, is that so that 111 online, they can call a GP or NHS 111, and whichever route they choose, they should get a similar experience. And that second point is really important, that NHS 111 makes it easier and safer for patients to get the right advice and treatment they urgently need, and increasingly be able to book a direct appointment or time slot. And I'll come back to that, Chair, during the presentation. And it is about then as well recognising the need to expand capacity, particularly within the NHS 111 service. And we actually nationally and locally did that. Colleagues on the call may remember that when we were in the first wave of the COVID epidemic, there was a significant increase in 111 capacity to deal with the advice and concerns that the public have. So this is very much about building upon what we've already got, but enhancing and developing an offer to patients through a digital route, but also to build up more capacity in the system locally. Next slide, please, Steve. So some key actions required and for the system as a whole is to ensure hospital EDs are safe by minimising unheralded attendances. So this is basically people who self-refer and attend because they believe they need some type of advice or input. And what NHS 111 first is trying to do is provide as many of those people who are unheralded that we can offer alternative support and advice. Or if they feel the need to attend ED, we've got a more planned way of doing that, so that the ED department has got an early warning that patient might be arriving. Obviously, increasing capacity in NHS 111, because that's both call handlers, but just as importantly, increasing clinical capacity, and that might be at the point where the individual member of the public has a call. And they may be at that point passed on to a clinician or very quickly turned around, so that wherever possible, the patient is given a treatment option there and then and isn't handed off to another clinician, another service. So it's boosting the clinical advice and treatment route for people and offering a different alternatives, as well as providing more local clinical advice through clinical advice services. backed up by a comprehensive public communication campaign. Now, I must emphasise at this point, Chair, that the NHS 111 system has not been launched formally yet. What we are doing as part of this process is trialling and testing some of the processes across Yorkshire and Humber with what we're calling a soft launch. So in other words, testing out some of the systems that when the public phone, we're routing them to that advice and treatment option. But what we haven't gone yet is the formal national campaign. Embed remote consultation models. So in other words, as I've mentioned, that we can actually provide online consultation as part of this offer through 111 First. We recognise the learning that's come out of COVID-19 and making remote working an opportunity for our clinical workforce so we can get better access to clinicians. Managing extremely clinical vulnerable patients and hospitals that's discharged from. So this is the one part of the NHS 111 offer is to enhance that support and identify rapidly where we may have vulnerable people who need some support both before or after hospital attendance. Make direct booking the norm rather than the exception, and that means not only in hospital but in general practice. And just to emphasise at this point, Chair, that for colleagues on the call who are not aware, that from a 111 perspective in terms of disposition, in other words, what the final route for public is, over 50% of all 111 dispositions are routed into general practice. So it's a really important message that already a large part of the 111 offer is not hospital related, and we're looking to increase the options outside of hospital setting in that place, and to ensure that hospital services work together to maximise the use of resources. So those messages about 111 First are really important. It's about getting people to the right place at the right time, offering them the input, and where they need to go to ED, that we can maximise that safely, but we offer many more options to the public. Next slide, please, Steve. And patient-centred outcomes. This is very much about the patient experience, about supporting the patient and the public, and so we want to ensure that there's a timely response. Assessed safely and effectively as directed to the right point of care, and that's really important. We want to make sure that there are not handoffs, that the people are getting a rapid response. Can be directed to the full spectrum. I mentioned that, Chair, about it might be advice around getting prescription, urgent dental services. We do see quite a number of calls around access, and we're picking it up as a separate work stream to see what we can do about that with it across West Yorkshire. There's a big role to play in our voluntary sector. And we know that we've got really good examples at place about how the voluntary sector supports particularly vulnerable people post-discharge or prior to discharge to support them in the home. So really that emphasis upon the whole gambit of the pathway of integrated care. Have an overall patient experience of NHS services as good as it can be, and have a mechanism of feedback where they are appropriate. So part of this process will be a number of key performance indicators so we can measure the impact of NHS 111, not just from a process perspective, but also from a patient experience perspective. Ensure patients go directly to the centre or clinic rather than via intermediary, and that's that point about no handoffs. Ensure patients are given an indicative time slot. There is an active conversation going on with ED departments at the moment, Chair, about when we talk about booking, what do we mean by that? And I think where we're getting to in the narrative is that where people do phone for 111 and it's agreed that clinically they need to go to ED, that we can give them an indication of a time slot. That is clearly dependent upon the pressure on the ED department, upon any urgent ambulance attendances. But the aim is to, from a patient experience perspective, to try and give more of a time slot, but also to give ED departments the flexibility around that. So we're working through that particular process at the moment. Managing flow of patients to ED by developing existing technical solutions. So again, that's about maximising digital opportunities. There's a lot of work going on about making better connectivity between IT systems so that people can get text, that we can make use of the modern telephone and other systems to support the patient. Have IT systems that allow providers to share patient information where it is appropriate, and have comprehensive, accurate, up-to-date information. So that whole issue about, it's very much about the patient experience, getting them in the right place and maximising the use of technology on understanding where we can route people and support people. Next slide, please. Capacity infrastructure, clearly what we need to understand, and colleagues will notice in some of the slides that this is very much about intelligence and data. We have through the current systems we have a lot of good information about where people elicit calls, the sort of services that they're getting. So we want to understand and manage demand and capacity as part of this process. Hospitals, clearly we're working with hospitals about their flow processes and managing patients. Walking to ED must remain available to those patients who require direct access. But we recognise not all patients will have use of a telephone or internet connection, so we're understanding how we can support, particularly perhaps those more individual and frail. That's where we bring in a lot of the support and development from our voluntary sector to support people to navigate through that. And commissioners and providers should consider how the current IT infrastructure can be improved. So a lot of the focus, as well as patient pathways, is about how we maximise our digital, particularly data sharing agreements, so we can actually get the patient record in the right place at the right time. Next slide, please, Steve. Clinical governance, that picks back when we make an ED referral, the referral service should routinely consider the potential clinical impact. So what this is about is what happens if we do advise an individual to attend either an urgent treatment centre or ED or whatever, and they don't. So we're very clear with clinicians, particularly about responsibility, about follow-up, etc., about where that sits in relation to clinical governance. Clearly, we want to make sure we've got the safest systems in place. Next slide, please, Steve. The next few slides, I don't want to go into a lot of detail on the next few slides, Chair, but what I wanted to show in this presentation, and hopefully it's coming across, this is very much an integrated urgent care offer, so that we've got a key role to play in a number of areas that working in collaboration. General practice, as we do know, is the fundamental offer. The vast majority of people who are seen within the NHS are seen within general practice. So as it says, it's the engine behind both routine and urgent. And a lot of the work, which you'll hear a little bit more at the end of this from Keith Wilson, is around working with general practice, the learning from general practice through COVID around remote consultation and offer, how we build that into the 111 first offer, understanding capacity in general practice in hours and out of hours, making sure that when we do all of this, that we're not doing a sort of too much of a left shift in terms of what current general practice capacity is, working in collaboration with general practice to make sure that we've got the right details around local directory of services, that we've got the right technical accessibility, that we're developing pathways at place level so that 111 first from a central perspective can route patients through to the right offer in a particular general practice, and we're clear about when that patient is routed, that they know what to expect, and also the practice knows what to expect. Really important. So NHS 111 can support practices by assessing if appropriate and giving advice. So the idea being that we can do a lot of triage at the 111 level, just as we would do from an ED perspective, to make sure that when that patient lands in a particular practice, we've already got a lot of information and we can get that right decision. Clearly, patient choice to phone 111 or book an appointment with their practice to access health should not influence the care they receive. So we've got a lot of local discussion going on. I think this is where this is a big scale issue. So we're doing this across Yorkshire and Humber, but I must emphasise that we're working with both 3 ICS systems, but we're also very much working with place. So this is very much built upon what the local offer is in either an ED department, in general practice or others. So that's that balancing up between maximising the opportunity of 111 at scale, but also making sure we've got that connectivity locally. Next slide, please, Steve. Really important. We know that there's been a lot of work done around supporting people with mental health pressures or problems. We know that there's quite a high call volume in 111 first with people with anxiety, with stress, with depression. And one of the key elements of the offer is to ensure that we've got a route and advice and support. One of the key elements of the NHS plan and the update this year was to ensure that we have mental health helplines open to the public. We're developing these in terms of pathways, and a key element of our work from a 111 first perspective is to ensure we've got the right level of advice and support, and we can route people urgently. We do know this is a growing pressure for individuals, and it's one of the key planks of both the national and local work. Next slide, please. Obviously, hospital systems, we're working closely with through our 3 programmes. So obviously in West Yorkshire and Harrogate, through the programme that Keith Wilson leads. So that's working with A&E boards, working with ED departments, working with that within West Yorkshire and Harrogate through Wyatt, understanding what systems are set up in place in trusts around same-day emergency care. We want to make sure that we don't step on some of the current practices that are in place and some of the pathways. We want to enhance the relationship between general practice and secondary care within place, and we want to make sure that NHS 111 First offers additionality to that process. Next slide, please. Clearly, ambulance services have got a key role to play, and this isn't just so that colleagues are aware. Yorkshire Ambulance Service are the NHS 111 provider, so that's hence why we're working very closely with them. That's not the case across the country. NHS 111 service provision is a different model in terms of different parts of the country. But this is very much why we're working on a Yorkshire and Humber basis, because Yorkshire Ambulance Services provide that 111 support. So really important that we have a coordinated approach and we have a systematic approach to implementation. And it's reminding us that ambulance services, not just about conveyance. A lot of what they do and they've done a lot more of through the COVID is that hear, treat and refer. So paramedics are highly trained clinicians in their own right, and they provide a lot of advice and treatment. And there are a lot of individuals who previously in years gone by might have found themselves in an ED department and others, so that the role of paramedics now is specifically changing. And we're making sure that we're bringing together the 999 and 111 pathways so that we can route the 999 calls, and paramedics have the opportunity to link in with that. So really important to emphasise, clearly ambulance service is very much about conveyance, but very much 21st century ambulance services are around the role that paramedics have in terms of either advising or treating, and that will continue to develop through this process. Next slide, please. So a little bit about implementation. Next slide, please, Steve. Just to sort of say again, a bit of a busy slide, apologise for that, but just to provide assurance to the committee, we have a programme, a group that pulls together programme leads. So for example, Keith Wilson as the programme director for urgent emergency care for West Yorkshire Harrogate sits on that group. We have senior colleagues from ambulance services from the other 2 ICSs, and links to NHSEI, technical support. So this is about making sure that the offer is as coordinated as possible, that we make best use of the resources that we've got from a 111 first perspective, but we are clear that when we work with individual integrated care systems and the wider place, that we bespoke it and we nuance it, so that we have a standard offer, but we can make sure that in local systems and processes that we maximise what's already in place and work to develop those pathways. What I would say is we've got a timeline that takes us to the 1st of December for the formal launch, and we've got a milestone. But what we will be doing is taking that beyond December to start to look at the longer term development of pathways. But we're currently, Chair, we are on track in terms of delivery of the programme. Next slide, please, Steve. This is just a bit about structure, just to show that the range of individuals that we've got in place here. This programme oversight group obviously is at a high level, but again emphasise that particularly in terms of West Yorkshire and Harrogate, Humber Coast and Vale and South Yorkshire and Bassetlaw, we have strong links through the programme leads into the local urgent care systems. That's been a really important element of that. Next slide, please. I won't go through these in detail, but if colleagues want to come back, so just highlight perhaps in terms of phasing. So we've got a phased approach. focus on align with national programmes. So we are increasing 111 capacity. We are in the middle of working with local ED departments about referral and booking. We're developing secondary care dispositions. Basically, what that means is a directory of services that we can ensure we can get people in the right place. So if it's a 111 call and somebody needs to get access to a same-day emergency care, we know which particular hospital and what type of service that is. We are developing other referral pathways. I've mentioned about mental health, really important. Keith will talk a little bit about 24/7 primary care, building on other pathways such as frailty. And obviously a big piece around communications, making sure that we've got the right engagement with local systems and the right communications with the public. Next slide, please. So a lot about data here. So this isn't just data, Chair, about performance. This is about understanding population need. So we can track, we understand right across Yorkshire and Humber where some of the hotspots are in terms of demand. We can look at what is already in place within local A&E boards, within local systems around need. We can understand how we can use 111 first to be more proactive in that place. So it's very much about using the data to do clinical modelling to look at what the group. So, for example, we know we have a lot of calls around under fives, and we're looking at what we can do in terms of supporting specific advice and treatment around those areas. High rates of calls with the elderly. So it's not just about performance, Chair. This is very much about mapping and about using the intelligence that we've got to help us develop the right pathways across Yorkshire and Humber, but particularly more locally. And of course, we will use that data to support our monitoring and evaluation of the impact of this. Next slide, please, Steve. We're now in the process of implementation, and those are the key areas that we're focusing on at the moment. I won't go into much more detail there. Next slide, please, Steve. So develop an integrated plan. We are now in the process of implementing that. We've got information sharing agreements across the place. That's been really important from an IG perspective. We are in the process of developing alternative pathways. The good news is that a lot of work has been done already right across the system, and obviously within West Yorkshire and Harrogate about pathways. And part of our integrated urgent care offer, as you know, Chair, is to work across the whole system to maximise in hospital and out of hospital. And a lot of training and development going on at the moment around health advisors, clinicians and others. So a lot of work, and I recognise at this point, Chair, that we are focusing on a launch in the 1st of December, but much of this work will continue to move into our planning for 21-22. I'll mention that a little bit more in the next presentation. And of course, we will have the post-implementation monitoring. Next slide, please, Steve. So that's a quick overview of 111 first from a national and regional perspective. And this slide, Keith's just going to briefly talk us through from a West Yorkshire and Harrogate perspective on what that means at a more local level. Keith, over to you.
Thank you, Pat, and thank you, Chair. I don't want to reiterate anything Pat has said, but in terms of a West Yorkshire and Harrogate approach, our key drivers are that only 3.4% of A&E attendances were referred there last financial year by 111, and most actually went there unilaterally or were conveyed by ambulance. Obviously, increased and unfettered access to A&E departments is a concern. COVID social distancing and staff absence have been impacting on what's already overstretched A&E capacity, but also increased triage from the early days of COVID have already demonstrated that that's got a positive impact on patients because it's getting them to the right advice and they're being directed to the right services if needed. Our big opportunities and one of our big focuses on West Yorkshire and Harrogate is around primary care access and availability, and we're interpreting that in its widest sense, not just GP in hours, but GP out of hours, extended access, community pharmacy and urgent treatment centres. Obviously, Pat's already mentioned around the increased call handling and clinical assessment capacity. We've got real opportunities through technology especially including video conferencing as well, across all parts of the UEC system that we can capitalise on. And we've got a real opportunity to communicate something different to the public. And this isn't about stopping them going to the service, but making sure we get them to the best place for the right care around it. Obviously, it really said that we want urgent treatment centres to be part of that integrated urgent and emergency care offer. And all of our places are currently looking at what's known as our directory of services associated with 111. And that's the yellow pages that actually call handlers and clinicians in 111 can use to actually identify, following talking to the patient, where is the best place for them to be seen if they do need to be seen. And that includes within that reviewing the ranking within that. We want emergency departments to be number 10 in the ranking, and we want a lot of alternative services well before that, so people actually get to the right place. As Pat has already said, last financial year within 111, it was well over 50, it was 56.9% of the dispositions within 111 were primary care in its widest sense. And that's the volume of people that we need to make sure get the right advice and get to the right service should they need to speak to someone or should they need a face-to-face appointment. So what are our priority areas? Well, obviously, of course, we're supporting the Yorkshire and Humber strategy around Talk Before You Walk. Our focus is on around telephone, online triage via both 111, 999 and general practice. We're currently working around how 111 will refer to emergency departments and currently still do refer to urgent treatment centres, and I hope to have that system in place ahead of a go live on the 1st of December. Obviously, all places are looking at any alternative or enhanced pathways, and we'll be looking in the months to come about perhaps are there some particular patient groups or symptoms where actually we could move people around the system differently and make sure they get to the right place. So this is certainly a very beginning of what we're looking to do around the 111 first model. And again, we are working as we speak and have been doing for several months now around a shared narrative and a coordinated approach to the public messages on accessing urgent and emergency care. We can't do this on our own. We very much rely on a wide range of our programmes in West Yorkshire and Harrogate to work with us. Some of that because we need their subject matter expertise, and some of that because we need them to lead on behalf of the wider system around that. And that includes primary and community care, mental health, children and young people, harnessing the power of communities, improving population health, personalised care, digital and workforce. And again, just to re-emphasise that, the reason that we've got are accelerating our work around those primary care alternatives is because those are the high volume. And while we will continue to work with acute trusts around referring into the ED department or where there are alternative sites such as same-day emergency care, we need to focus on where we're going to get those high volumes of people through. And that's it from me, Chair. So Pat and I are open to any questions.
Thank you very much, Keith. Thank you, Pat. Very, very extensive and a lot of work going on. I'll bring in Steve Ollerton first, please. Steve. Steve, you're on mute. Steve, on mute. Okay, mate.
Sorry, and I've just said all the good bits. Yeah, thanks, Pat and Keith. Just a load of comments, really. I mean, really exciting work. We know a lot of the work that goes on in EDs is primary care work, and we've never been able to deal with that. I do like this idea of 111 EDs and GPs being able to book into each other. Really hard to do, but it's how we should be doing it. Quite how we get patients who are walking into emergency departments to access 111 is an interesting one, and I know it's been tried in places like Blackpool and stuff like that, but Ideally, they need to be phoning 111 before they even get there, but we will never stop patients turning up at ED until we get a better offer somewhere else for them. I think you know, in primary care at the moment, we've been doing a lot of e-consultations. I mean, everybody will be aware that when you phone 111, you get 50 questions. And actually, that's the same when you do an e-consult for general practice now. So actually, you could make 111 much more efficient by getting patients to actually fill in a lot of the questions before they even speak to anybody at 111. I don't know how much you've explored that. But it will certainly save time for 111. And then at the other end of 111, we need better signposting, because actually 56% of those being directed to general practice, I can tell you that as soon as those people are then phoning my surgery, they will be getting directed to opticians, to first contact physios, to mental health. They don't need to speak to their general practice. Some of them do, but not all of them do. And then just a final comment. What I found really useful recently is when patients are being sent through to general practice from 111, the documentation has got there ahead of them. And that's really helpful when I'm dealing with them. And I'm pretty sure that doesn't happen in emergency departments. So if you've got patients turning up in emergency departments, they don't know what other bits of the system they've contacted earlier that day. And the sooner we can get that slicker, so that the triage nurses or whatever in ED can actually see, oh, they've phoned 111, they've been to general practice, they've been to wherever already, much easier to deal with the patients when you've got that information. Anyway, keep up the good work. Thanks.
Great, thanks, Steve. Really comprehensive that, and I'm hoping Keith and Pat are making notes on there. I'm just going to bring Tim in, please, as well. Tim Riley.
Yeah, just a couple of questions, really. I'd echo a lot of what Steve has said in terms of, I do think bringing together general practice, 111, ED, and so on, into a single system to deal with sort of same-day responses is absolutely the way we should be going. So a huge amount of work, and also understand that in order to do that, we're going to have to put a lot of work in, is what you've described around the infrastructure behind the scenes, looking at where the capacity is and so on. So I'm very supportive of that. I guess just two questions, really. One is, can I understand a little bit more around what we're doing about the behavioural shift that we're going to have to bring about in the population, and what the learning is from elsewhere and other places and pilots and so on about what we need to do about that? Because I think it's fine saying we've got a comms message, but I think this is about changing behaviour at a very fundamental level. Most of us have been used, well, you know, I'm 50 something, and I've been using A&E in a certain way for all that time, and I think that's changed. So that's the first question, just a bit more understanding about that and where that resource is coming from. And then I suppose secondly, it's a little bit about how we're planning, once this is implemented, to monitor it. I mean, I think the left shift, given the history of investment in diversion schemes, for want of a better term, actually has pretty poor track record. Where is and how are we going to monitor this going forward to ensure that it does work, and if it's not working, that we can take appropriate actions, and indeed if it really doesn't work, go back to the drawing board? And I'm just not quite sure that's being talked through. So just a little bit of further on that.
Okay, Pat or Keith, do you want to come back on that? Yeah, Pat.
I'll have a go first, Chair. I think those two. Thanks for that. I think the two questions are interrelated. So something about that behavioural piece. So I mean, we talk about left shift, I suppose, but going back to that discussion about data and intelligence, there's something about population and about where emergency care actually starts, what the journey is, and it's long before people are pitching up at ED. It's about actually understanding behaviour within individual parts of the geography. What are the issues about getting access to general practice or other areas? What, you know, I raised dentistry on the call as a good example. For example, about that we get quite a high volume of calls in West Yorkshire and Harrogate around dentistry. You know, there's something, you know, there's a message there perhaps about what the current state of those services are, and what is the answer to that in a strategic way. But I think that behavioural change a bit is a lot about where the narrative, certainly in West Yorkshire and Harrogate, is about engaging with local places, understanding the trends. Why do people access ED departments. And I totally agree with, I've worked on many years on hospital avoidance schemes. And, you know, you've probably seen some more business cases than I have about how we can divert lots and lots of patients, and that'll save lots of money, and that'll be, we know that there's a bigger conversation around. And I think we're using, in the longer term, that thing about integrating primary care, secondary care in the system. We have a different conversation about behaviour and about expectations, and we use our local mechanisms, the voluntary sector I've mentioned. So it's very much about, not about hospital avoidance, but it is about how we support people who are pitching up in emergency departments and are needing access to general practice. We need to have a bigger conversation probably going forward about, given that disposition around general practice and some of the comments Steve made, about what the system narrative going forward is about integrated urgent care. Because for I think a number of years, understandably, it's been focused about an ED department, an ED. And actually, that's part of the issue, but it's a much bigger conversation. So that's that. And then monitoring evaluation, we are trying to understand not just about what it means to ED attendances in general, but actually what are the types of dispositions that are having an impact? What can we do as a system? But there is a much bigger conversation outside of EDs. I don't know if that helps. That's the narrative that we're trying to get to.
Okay, thanks, Pat. I'll Keith, do you want to come back in on that?
Yeah, Chair, if I can add to it, if you wouldn't mind, and I'll be very brief around it. We already know people are already using 111 more now during COVID. We've seen significant increases in 111 online. For the first time in a long time across West Yorkshire and Harrogate, we've got a really good, strong shared narrative about where to go and what to do and choosing the right service. We've based some of that, Tim, based on the work that your comms leads have already done in Leeds around it. In terms of Steve mentioning about the patient information coming, we're aiming by the end of November that there will be a system in place that all EDs will get the patient information sent to them. And we've seen what that looks like. It's pretty comprehensive around it. And finally, around monitoring and evaluation, we are currently talking with the North East around the work that they've been doing, and there's quite a significant big data set that we could use that would show that channel shift or not around it. So, you know, as a result of pressing that button on the 1st of December, are we seeing increases of people phoning 111? And therefore, on that, are we seeing more people going to community pharmacy, going to extended access? You know, so we should be able to monitor that in the months ahead around that. And obviously with that, we'd need to pause and reflect on that. If it's not doing what we think it's going to be doing, we need to be thinking about what needs to change within the system.
Okay, thanks, Keith. I've got 3 people with their hands up. I'm going to take these 3 questions, then we're going to have to move on. But if we can also note what people are saying, Pat and Keith, because obviously you'll need to take it back. John first, then Joe, then Jason, please. John.
Thank you, Chair. Without going into too much history about any of this, I'm with Tim, and I think there's something we really need to think about when this comes back. And Keith, I hear you're collecting data, but the challenges are not just about we're getting a lot of dentistry calls, and the dentistry disposition is about urgent care within 24 hours, and therefore you manage that through. It's actually about the connection around public's behaviour and change and what they say. So you're getting a lot of online use at the moment because people have a perception that there's no alternative. So the only substitute is through 111 online. But the thing I would say is that the thing for you just to keep an eye on is not how many people 111 recommends go to ED. It's how many people 111 recommends don't go to ED, but turn up anyway and say that 111 has sent them. And that's your trap that both annoys the ED and doesn't help you drive those public perceptions of the best place to go. So I'll pause there, Chair. Thank you.
Okay, thank you very much indeed. I think we're nodding from there from Pat and Keith. Thanks for that. Joe, please, next.
It's on the same line really, so I won't repeat it, but I do think this issue of social behaviour is a nut that we've been trying to crack for a long time, and I think we saw something magnificent in March as well as something tragic around COVID, because the whole biggest social movement happened. And I think there's a lot of studies around what actually happened and how people behaved and responded to that. We know people stopped coming for the wrong reasons, but there is something about how do we capture the learning from what happened around March, April time, around how people did make different choices about how they actually access healthcare, and how do we embed that into the way in which we work now, because the biggest asset we have is people, and the sustainability of our healthcare system is around people, and we knew that urgent care demand were rising. What I've seen locally in Wakefield is that unfortunately, you know, urgent care is rising alongside COVID infections, and we really do need to grasp hold of this. So I think it's about having good comms messages, but I do think we need more around social movement across West Yorkshire, and we need to use the assets of the partnership to be able to try and think outside the box around how we do that.
Okay, thank you, Jo. I'll bring Jason, then Naheem, please. Jason, please.
Yeah, I think I'm going back a little bit to Tim's point again, but you know, when you read through the documents, there's lots of mention of services, you know, whether it's 111, whether it's GP, whether it's ED, whatever. The people that are turning up in those services are just the tip of the iceberg. And I sometimes wonder, especially when we're talking about joint information, joint aspirations for a population health management approach, are we really going back far enough to understand the need? Because fundamentally, the reason that people turn up in places we don't expect them to is that they're basically not getting the answer to their problem, and we're providing services that perhaps solve a problem we think is there, and I'm just not sure we're learning that lesson and are going far enough to understand the actual need of those population subgroups. I think that's the question for me.
Okay, thank you very much indeed, Jason. Khalid, please.
Thank you very much. I think the question of the need of patient is definitely very valid, and at the same time, how we are going to bring about this this mindset of our population, that's another challenge. And one more thing which I thought is important is the competence of the people who are who are handling those calls, and the professional support available to them is also extremely important. And especially one of my colleagues has just raised the point of the patients who turn up at A&E and who were told by 111, go there and don't tell, and then tell them that you've been sent by 111. Whether the patient is telling the truth, or whether they are the people sitting on that end of the phone are not confident enough about their decision. So in my opinion, there may be some training need. There may be some lack of competent support for those peoples, for call handlers. Thank you.
Thank you, Khalid. Okay, Pat, Keith, you've got lots of comments there and feedback there. I hope you'll take that away with you and listen to what we're saying. Yeah, happy
Thanks,
with that, Pat, Keith?
Yeah.
Okay,
Yeah,
thank you,
you,
everybody. I'm going to move on to the next agenda item, if I may, then, because I know this involves Pat, and I think it'll be Rod, won't it, from the Ambulance Trust. So, Pat, if I can hand back over to you for the next item, please.
Yeah, thanks, Chair. Steve, are you able to put the next presentation on, please? So thanks. So there's a bit of a joined up narrative here between the last presentation and this one. So this is the work that we've been doing from the back end of last year, and really what I want to talk through just fairly briefly is how we're trying to work with Yorkshire and Humber, across Yorkshire and Humber, sorry, with Yorkshire Ambulance Services, the main provider of a lot of our integrated emergency care services, and how we can get a more joined up and coordinated commissioning framework, but we don't lose sight of very much, which is I know very much an issue in this part of the world, is that we don't lose sight of the place narrative, and we try and get that balance between scale, between effectiveness and efficiency on the one hand, but we also get that need to be responsive to the local system as well. So Steve, you can move on to the next slide, please. So just a bit of background. So so the Yorkshire and Humber Strategic Partnership Board, which brings together key decision makers across Yorkshire and Humber and Yaz, which, to be fair, has since the development of ICSs probably was something we needed to reflect upon in terms of who was part of that process, how we actually came together as a wider system, and what our decision-making processes were. But so that group itself instigated a review of the way that commissioning, joint planning, performance, finance, etc., was organised across that footprint. So between November and February, between November 19 and February this year, a task and finish group met, and we came up with a proposed operating model. That was just about to be taken forward when clearly we had the impact of COVID-19, but that was picked up again in May of this year, and we've been since that time working across the system, updating Yorkshire and Humber CCG accountable officers. We've now had 3 presentations in terms of the development of the framework, what we're trying to do, what its aims were. And in July, a presentation proposed an HS 111 first, utilising an integrated commissioning. So that first narrative that you just seen, we've been keeping the wider system up to date. We also used the opportunity to present and discuss the framework that I'm now going to be presenting. And on the call that we had with AOs at the end of last month, we received support for that direction of travel. So what you're now seeing, we've got signed up in principle. We're now talking about implementation. Obviously, today is providing colleagues with an update today. Next slide, please, Steve. So little bit of a busy model, but what the operating model aims to show, and I hope it does that, is that at the bottom of the slide we have Yorkshire Ambulance Services as a key partner, and we know that Yorkshire Ambulance Services have got connections with CCGs as both commissioners and leaders of local and developers of local systems. They work with local providers. Yaz attend and sit on A&E boards right across Yorkshire and Humber, so they're connected with. There are transport issues that they develop with the third sector, local authorities. So that's recognising that Yorkshire Ambulance as a service and as a provider of quite a significant amount of integrated emergency care are a key partner. So that's that relationship that we want to build upon and develop, and that's obviously then the building blocks. So then through the 3 ICS and the recognition that all 3 integrated care systems are in a different place in terms of and have been over the last 18 months, 2 years. But the ambition is through this process that we develop both a shared narrative and also a way of working together, that we're working across systematically in a more coordinated approach across those 3 integrated care systems. And JSPB recognised that we needed to change and develop the way that Yorkshire Ambulance Services developed and services and were commissioned by these services. So that's very much about joining up that top of the shop, which is about coming up with an agreement about resources, quality and delivery and key performance outcomes. So we have a shared vision of how we operate. So fairly simple in terms of the lines, but obviously managing the complexity of 3 ICSs and the range of urgent care systems, but at the same time developing a more integrated approach. And I think something that was said I know I heard in the earlier presentation about commissioning futures. This is very much going away from commissioner-provider relationship to a partnership arrangement, still underpinned by some robust issues around finance, etc. So that's the aim of the operating model, is to create a greater level of reality about this aspiration. Next slide, please. So this is work in progress, but basically what this slide presents is that we have across the top there, we have the key partners who are Yorkshire Ambulance Service, the 3 ICSs, and I've highlighted for this purpose, this presentation, obviously West Yorkshire and Harrogate. We also have an integrated commissioning central support team, which we already have in place. Now, a lot of that, colleagues on the call would think would look fairly familiar in terms of a commissioning approach. What we're wanting to do with this is to have a much more joined up approach between those dynamics across the three ICS footprints and YAS, with the issues around how we manage our financial envelopes in a different context going forward. And obviously there's a lot more in the planning guidance now about that. Definitely a much stronger narrative around a shared understanding about service developments and transformation. So it is not a transactional conversation about commissioning intentions, but it's a joint understanding of where we want to take integrated and urgent to make services patient orientated across the Yorkshire Underfit, but that we can build strong integrated urgent emergency care, working with YAS as a partner, still holding the issues around governance, financial probity, etc. We're not losing sight of the need of public accountability and finance, but we absolutely want to move the narrative, and some of that we've heard earlier on today, and obviously that quality and safety patient experience. So I won't go. So there's something about just the mechanisms for doing that, and we're exploring at the moment. We have a workshop being developed for early November, which starts to articulate more how we create that integrated commissioning forum. We've got a number of committees and groups that meet, and there's a recognition that we need to make better connections between them. What our ambition is that through the Yorkshire and Humber Integrated Urgent Emergency Care Joint Strategic Partnership Board, which we'd like to re-energise, we have one agreed strategic direction, we have agreed priorities, but we then have mechanisms for the way that those are then enacted. Next slide, please. So some principles here that we've very much worked upon about what would be the principles underpinning this. So we'd have agreed shared vision. We would have agreed shared strategic priorities over the next 3 to 5 years. We'd ensure a focus on a whole pathway approach. And I think we've heard a lot of that, Chair, from the last presentation about integrated urgent care across the whole system. Ensuring a shared understanding of data information. And this is a crucial one. We don't have a paucity of data and information. In fact, we've got quite a bit. What we want to create is a single version of the truth, so that we're holding each other mutually account in delivering patient-oriented outcomes and delivery. So we have a single voice in the way that we communicate and make decisions across that system. Next slide, please. And then behaviours, and this is something that colleagues have really wanted us to focus on. We commit to behaving consistently as leaders in ways that we model and promote shared values, support each other and working collaboratively. We act with honesty and integrity. We want to do the right thing. We challenge constructively as a system. We assume good intentions. We implement shared priorities and decisions, holding each other mutually to account. And that is very much about it's a shared accountability for delivery. We're holding each other to account. Those may be common and they may be obvious, but we felt it was really important that they underpin the way that we want to work going forward. Next slide, please, Steve. And the model, very quickly, YAS are a key partner in this process. We organisations work effectively, and so there's very much looking to working with ICSs and their ambition to work differently moving forward in the way that we communicate and operate. We recognise still that in this context, A&E delivery boards and local place-based dialogue is really, really important going forward. ICS urgent emergent care programmes are informed cross-cutting programmes. Keith mentioned that. We recognise the work that's taking place in developing pathways. This is really important, all three ICSs, and we've got sign up to this working mutual partnership with YAS and one coordinated approach. And this forum is supported by a shared infrastructure. So we've got a current team and we want to make sure that we maximise that team. Next slide, please. And again, I just put this slide in because I know that I thought it was just a brief opportunity to perhaps just to share with the committee how we think, just one example of how that system may translate itself into that commissioning futures narrative that we heard earlier on from Joe and Esther. So the next slide, please. And this is my version of this, so apologies, but in terms of the understanding of it. But I wanted to emphasise, because there's a challenge, isn't it? When we do things at scale, there's a concern that we lose sight of the local element of that. So if I use that framework in the context of commissioning futures, so at place, it's the do it 5 times tailored to place. I think that's the 111 to local CAS narrative, and we've heard some of that in the earlier conversation. How do we bespoke that call and get the patient to the right place at the right time? And that's very much about what local systems have in place, and that's more tailored going back to that population-based need bit, that's more tailored to local need and local provision, but we do it 5 times and it's tailored. There could be then do it 5 times the same, that's mental health intervention pathways. So we have standard interventions that we are evidence-based. We need to implement them 5 times, but we need to make sure we've got a consistency in the way that those are actually developed and delivered. I think that the third pillar of that is in the way that the commissioning futures is obviously at the West Yorkshire and Harrogate ICS level, and that would be a good example of that is the work that we've been doing with LCD, out of our support. So that's a once narrative that we've developed across West Yorkshire and Humber. That's very much linked into the way that we're going to work going forward. I would offer another tier then, which is a Yorkshire and Humber level, where we deliver it once, but we do it consistently right across a wider footprint, and that's obviously the 111 call handling and triage. So what I wanted to do, Chair, just I suppose, just to provide a bit of context, that it is absolutely about scale. It is about a different relationship, very much mirroring what's happening in West Yorkshire and Harrogate about commissioning futures, but it's about that relationship across 3 different ICSs and recognising the differences, but also the common opportunities that we've got, working with Yaz as a key partner, changing the narrative into a partnership arrangement, a shared vision and understanding, but recognising there will always be a tension between scalability, effectiveness and efficiency, standardisation, and the need to nuance that at a local level. I'll stop there, Chair.
Thank you very much indeed, Pat. Yet again, a good presentation, a lot of work going on. Did Rod want to come in on any of that at all, Pat?
Rod?
Thanks, Pat. Thanks, Chair. Pat, I mean, you've articulated it really well. I think, Joe and myself who have been trying to sort of take forward this agenda for a number of years now would say, one of the challenges has been really getting the right level of strategic engagement. So something that really focuses on what our priorities should be on a scale and tries to get a common narrative about doing a few things well, I think will really allow us to move forward at pace, and actually, and that doesn't impinge on meeting local place needs as well. As a service, one of the challenges that we've had is engaging with commissioning when you're looking across 3 different service lines that are treated as 3 silos, when that's less and less the case, but also then dividing that narrative between, depending on which service it is, somewhere between 16 and 21 CCGs through nobody's fault. Just trying to facilitate those discussions, let alone get a coherent narrative across them, has proved really difficult, when actually, when you do talk to people at local place, there are some common themes and some real opportunities to agree priorities and take things forward in a coordinated way. So, we think this is a really positive move forward across all three of our service lines. And in terms of the way that we're looking to engage as an organisation, fits with our model of, yes, there'll be some things that we do across the region where there's an internal benefit to doing things at scale. But we very much want to integrate our services in local places as well, and have stronger clinical leadership at place that can interact, get an understanding of what priorities are, and work with local teams to take those forward. So I think this structure and approach really helps with that, and timing wise, it's an ideal time to do it.
Thank you, Rod. Okay, I'll open up to the committee then. Any comments? I mean, we're very much commission it once anyway. We've been doing this for a while in West Yorkshire. We make some decisions on the ambulance trust from a while ago. So anything any of my colleagues want to pick up or raise with either Rod or Pat? I can't see any hands, guys. Oh, yes, I have. Joe, please.
I feel like I need to say something, so I will.
And the only thing I would say is that this approach to how we want to continue to work with Yorkshire Ambulance Service as a provider fits with the model of commissioning around partnership commissioning, and the 3 tiers fits with our commissioning futures approach anyway. So I think we're all aligned now, and it's really helpful that that's been agreed across a Yorkshire and Humber footprint, which allows Rod and his team to engage much more effectively, I think, with the 3 ICSs that support the Yorkshire and Humber system. So that's all I would say, really, that it's strategically aligned to where we're going and what we're doing.
Okay, thank you very much indeed. John, please, John Malyoe.
I'll be really brief, Chair. Thank you. So, Rod, Pat, thank you for that. I think the thing for me is the direction of travel is right, isn't it? It's about consistency and integration. And the thing I'd like to see as the measure of success for this, for me, would be about when you start talking about place, and I'm talking about place in its smallest sense there, and you talk about in the slide deck, it says, doing things maybe 5 times. I think the opportunity is to share the good practice and the consistency around those places. So actually there's more cohesion in the local model as well.
Okay, thank you very much for that, John. I think we're getting nods there from both Pat and Rod anyway. Okay, any other comments? So we're asked, guys, to note the contents and the work of the Development Humber Framework and note the support and propose the next steps, and I think we're doing that in full. So on behalf of myself, Pat, Rod and the committee, thank you very much indeed for that paper today and noting where we are and bringing it all together. So thank you, everybody.
Thanks, Jeff. Thank you.
Okay, thank you, committee members. I think that's, now that we're going in the wrong order, we've gone through them backwards more or less, but we've managed to get there. So thank you very much for everybody for fitting in the time slots. The next question, is there any other business anybody would wish to raise that was not raised today that you wish to raise? No, I can't see any new hands. Joe, your hand's up. Is that from last time?
Yes, sorry.
Okay, no problem. Okay, well, on behalf of myself and the committee then to everybody, thank you very much indeed. Our next meeting in public will be Tuesday, the 12th of January 2021, 11 a.m. to 1 p.m. There you go. Gosh, that's New Year. Well, happy Christmas, everybody. Happy New Year in public. No, on behalf of myself, thank you, everybody, and have a great day. Thank you very much indeed.
Thanks, Marie.
Thanks, Marie.
Thanks, guys.
Thanks, Marie.
Bye-bye.